So we have three topics, interesting topics for today's discussion, today's afternoons. So following the discussion, we can have the, following the presentation, we can have the discussion at the end. So the first topic would be on the retinopathy, the diagnosis of retinopathy, an interesting topic because it is not a new subject, but it is actually the first image was actually captured in the year 1886, so many years before. I think Dr. Moses, Dr. Wilma Moses is there with us to discuss about the recent advances and the upcoming interesting news about the imaging techniques in the diabetic retinopathy. Over to you, madam.
Thank you, sir, for the introduction. Good afternoon, everyone. So at the outset, I'd like to thank the organizing committee for giving me this opportunity. So this topic, imaging in diabetic retinopathy, the future, is actually a very relevant topic because as we know, retinopathy is one of the leading causes of blindness in working age adults. And in India, the prevalence of retinopathy is found to be around 12.5% among diabetics, and amongst that, at least 4% of those cases would be considered vision-threatening diabetic retinopathy. So delayed detection is one of the main causes for irreversible vision loss in such patients, and imaging plays a crucial role in early diagnosis as such. So I think this we would all know, diabetic retinopathy is broadly classified as non-proliferative and proliferative. Non-proliferative is further classified into mild, moderate and severe based on the ETDRS study group criteria. Apart from that, we have maculopathy, which is further classified as focal or diffuse macular edema. So what we would consider as vision-threatening diabetic retinopathy includes someone with macular edema, with proliferative retinopathy, or advanced diabetic eye disease, which includes vitreous hemorrhage, tractional retinal detachment, or neovascular glaucoma. So why is imaging important? So one aspect is, it is critical for staging the retinopathy. So the ETDRS, the criteria which we had seen earlier, this is actually based on the fundus images which we acquire. The second, of course, would be to assess and triage which patients would warrant referral to a retina specialist, and of course for follow-up records. And the main aspect, the crucial aspect, is to decide the treatment strategies, that is such as OCT for macular edema or FFA for PDR for lasers as such. So this non-mediatic fundus photography is the standard one which is usually done routinely in all our OP setups. So this is based on an infrared technology which captures even in a dimly lit room. And so there are other options such as portable fundus, non-mediatic fundus photography, and also smartphone-based alternatives which are also available. So the main advantage, of course, we do not really need to dilate the patient, so the patient is more comfortable. But the only thing is at the cost of the image quality, which might be lower, and cataracts, even early cataracts can hamper the clarity of the images. And also the main thing is the field of view is significantly lesser. So only 30 degrees of the retina is actually imaged in this. So this standard fundus photography is what is ideally done according to the ETDRS protocol, where we take a montage of around 7 pictures covering the various quadrants of the retina, and this will cover at least 90 degrees of the retina. So of course, similarly, these also have some limitations, as in this needs dilation, and it's more technician and patient cooperation dependent. And of course, the cameras are non-portable, so this might not be useful when we are screening large number of patients in a camp setup or elsewhere. So as of now, clinical examination with an indirect ophthalmoscopy is still considered the gold standard for diabetic retinopathy detection. And when we compare the sensitivity of non-mediatic fundus photography to that, it is significantly lesser. Non-mediatic is significantly lesser. But standard fundus photography is almost similar. The sensitivity is around 93%. So there are some other studies which have seen, some meta-analysis studies which say that these smartphone or the non-mydriatic cameras are not very sensitive to detect early NPDR, that is mild or moderate NPDR, and also crucially diabetic macular edema can also get mixed out in these fundus photos because we don't really get a binocular field of view in this. For proliferative diabetic retinopathy, on the other hand, it is equally as sensitive as doing a clinical examination. So the newer advances which we're seeing now are ultra-wide field imaging, where the fundus camera captures a high resolution view of the posterior pole and the peripheral retina in a single image. So as much as 200 degrees of the retina, the field of view of the retina can be obtained in a single image, and this covers around 82% of the retina. So these are the four algorithms which are available, the platforms which are available as of now. So if we see this picture, we can see that the wide field covers around 200 degrees, and the standard field, the central area which is marked, is a very minimal area. It is actually only 1/3 of the retina which is actually being screened in a routine practice. So we tend to miss out a lot of peripheral lesions, such as blot hemorrhages or perfusion, non-perfusion areas. And these predominantly peripheral lesions have an increased risk for worsening DR. So this is associated with 4 times more chance of the patient progressing from NPDR to PDR in 4 years. And hence, this helps in early diagnosis of pre-proliferative retinopathy. So the sensitivity as such, if we compare to a standard montage fundus photography, we can see that ultra-wide field definitely scores better. It is almost equivalent to doing a regular clinical examination. And it captures with a single image, that is, we don't need multiple captures, and it does not require dilation. The major limitation, of course, which we are facing as of now is the significantly higher cost, hence it is not very accessible as of now. So another imaging, an important imaging aspect is the imaging of the retinal thickness. So OCT, that is optical coherence tomography, helps in that. This is a non-invasive imaging which captures the cross-sectional image of the retina, and we get a quantitative analysis of the retinal or the foveal thickness as such. So in macular edema, the foveal thickness is usually increased. So not only for diagnosing macular edema, we can also assess whether the treatment modalities are actually working or not. So this is the only, as of now, this is the only quantitative analysis which is available when we look at all the fundus imaging modalities. So of course, FFA, fundus fluorescent angiography, is a time-tested technique which has been there for many decades together. And this this is an invasive test, and fluorescent dye is injected and fundus images are usually captured with this. So this mainly helps to detect any leakage areas like neovascularization of the disc or elsewhere, and also in the macula, any leakage in the macula signifying macular edema. And another aspect is it helps to detect any non-perfusion areas, that is capillary non-perfusion, or macular ischemia, which can be an indicator of unexplained vision loss in retinopathy. So similar to the ultra-wide field fundus imaging, we have the ultra-wide field FFA, which is also available nowadays. So this, using this, a new entity has been discovered called the PVL, that is the peripheral vessel leakage, where only the peripheral ischemia sets in earlier, and this is an indicator of active pre-proliferative retinopathy, and this indicates that the patient has a very high chance of developing NPDR, neovascularization. So there is 10% more chance of picking up neovascularization using the ultra-wide field FFA. And hence, the earlier we pick up, the more chances of early treatment, which would enable us to give good visual outcomes for such patients. So apart from diagnosing, it also helps in targeted retinal photocoagulation. So PRP, that is pan-retinal photocoagulation, which is what is routinely done nowadays, is actually a destructive procedure where we apply the retinal laser to around 360 degrees of the retina all around. So this targeted retinal photocoagulation would help us to concentrate on only the ischemic areas, and it will help us to retain some amount of structural integrity for the retina. So new exciting imaging modality which has been seen in the recent years is OCT angio or angiography Octa. So this is a completely non-invasive and a dye-free test. So compared to an FFA, we don't really need a dye. And so this can be very useful in patients where they have altered renal parameters, and hence, we cannot do an FFA in such patients. So instead of using an infrared light here, we actually use an ultrasound B scan in this, and it takes multiple images of the various layers of the retina. So we can see the cross section or the cut section of various layers like the superficial capillary plexus and the deep capillary plexus separately in this. So this can help to detect microvascular changes even before the clinical retinopathy sets in, and we can additionally also see the ischemic status of the macula, that is any perfusion, reduction in macular perfusion, and also for NVE. So the major limitation of this as of now is that the traditional Octa which is available now has a very small field of view, that is only 6 millimeters. So of course there are upcoming softwares which have a wide field Octa also available, and this will probably help us to pick out NVE and NVD. So this completely would negate the need for an FFA in the future, in the distant future now. So artificial intelligence, I think we know it's the buzzword when it comes to imaging nowadays, and diabetic retinopathy is one of the main ocular conditions where a completely AI-dependent software has been developed for detecting and staging retinopathy. So how this actually works is multiple large data set of retina images are fed into the algorithm, and these deep learning models are used to compare and detect various lesions in the retina in the various pictures, and it helps to stage and recognize whether the patient has retinopathy or not, and also the severity of the retinopathy. So multiple algorithms are available. Some are FDA approved and some Indian approved AI models are also available as of now. And so this is a sample of the report we can get with AI software. So this result would, it would give a result as vision threatening diabetic retinopathy, or some algorithms even give us the staging also. So the sensitivity is very good. It is around 87% and specificity is also 90%, which is pretty good. So the algorithms as such help us in early detection and faster acquisition times. And of course, it enables better accessibility. So in the long run, it will be resource efficient also, when we can screen a large number of patients with AI-dependent software and fundus photography models. Excuse me. Yeah, so of course the challenges, there are some challenges we face even with AI. One is an algorithm bias, because not all algorithms stage the retinopathy equally the same, and there are some changes which are noted, slight differences which are noted in the grading systems, and there is a need for validation in a diverse racial population. And of course the imaging is very much quality based, so it depends on if we give a good quality image, there is better chance of the AI picking out the lesions better. So it is completely patient dependent and technician dependent also. And the main thing we notice is there is a lack of stereoscopy in these images, so binocular vision as such is not there. So macular edema might get missed out in these images. So as such, it is ideal for detecting NPDR or PDR, but for macular edema, the sensitivity is not very good. And of course, there is an ethical concern because we are feeding a large number of retina images of patients into an open algorithm, and this might create some security reasons in the long run. So some recent advances which we're seeing in the distant future would be adaptive optics imaging, where a cellular level resolution can be obtained with OCT, and we can see the microvascular changes and capillary changes even in early retinopathy stages. The other thing would be color Doppler imaging, where a significant reduction in blood flow velocity and increased resistance in the vessels denotes early or pre-proliferative diabetic retinopathy. And retinal oximetry is another upcoming imaging modality which we are seeing, where oxygen saturation in various retinal vessels can be measured early. So this gives us an idea of where the retinal ischemia is and the metabolic status also. So another thing, of course, is the fluorescent lifetime imaging ophthalmoscopy, FLIO, and this assesses the retinal fluorophores, which are the metabolic pigments which are present in the retina, and this can give us an idea about early metabolic changes which are occurring in the retina, especially in case of macular edema. So these are, of course, in the very early stages. They are promising, but they are still largely in the prototype or research stages. So to conclude, as we can see, from detection to decision making, imaging is the cornerstone of diabetic retinopathy management. And the key trends we are noticing are move towards more non-mydriatic, non-invasive, high resolution and wide field imaging. AI integration has revolutionized telemedicine, and it helps us in increasing access in underdeserved areas and also for timely appropriate referral. The future probably lies in predictive, personalized, multimodal screening, combining all the imaging modalities, including FFA, fundus photography, OCT, OCTA, and the other earlier detection methods. Thank you. Thank you.
So thank you for the eye-opening presentation, Dr. Vilma. I think we can move on to the next session.
The next session, the speaker is Dr. C. Muralidharan. He's going to talk about MASLD and diabetes interface. Over to
Good evening, friends. It gives me immense pleasure to be with you. Kudos to the organizing committee for this wonderful conference, and thank you for inviting me as one of the faculties. The topic given to me is MASLD and diabetes interface. Yes, MASLD is a hidden epidemic. Diabetes is a known epidemic, so we are dealing with a dual epidemic. Both of them are linked to each other. MASLD and type 2 DM, they have a synergistic, bidirectional relationship where each condition worsens the other. T2DM is a major risk factor for MASLD, while MASLD in turn accelerates the progression of diabetes and increase the risk of severe MASLD forms like MASH. What is the underlying mechanism for both the conditions? Insulin resistance, systemic inflammation, and the fatty liver disease. How these MASLD and diabetes influence each other? Number one, diabetes drives MASLD progression due to high blood sugar, which leads to progression of MASLD to more severe forms. Whereas MASLD increases a diabetes risk because itself is considered as a pre-diabetic condition, significantly increasing the risk of developing type 2 DM. So both the conditions are strongly linked to metabolic syndrome components such as obesity and insulin resistance. So it is a global epidemic. MASLD, high prevalence in the obesity, around 75%, and higher prevalence in diabetes, around 69%. The nomenclature has been changed, accepted by a multi-society Delphi consent statement. Yes, NAFLD is now MASLD, metabolic dysfunction associated steatotic liver disease. Yes, MASLD is redefined. Why MASLD in 2023? It is, this term is inclusive, non-stigmatizing, and pathophysiologically it is accurate. Supported by 236 experts, 56 country Delphi consensus. So why MASLD? Because of the strong association with metabolic disorders. When you call the condition as MASLD, yeah, there are two important components. One is a steatotic liver disease, that is more than 5% fat accumulation in the liver. Number two, at least one cardiometabolic risk factor like elevated TG, low HDL, T2DM or prediabetes, obesity, or high blood pressure. So MASLD, higher prevalence, 7 out of 10 type 2 diabetic patients have MASLD. So there is a higher prevalence of steatosis and fibrosis, amounting to 75% of the prevalence of steatosis and 29% of liver fibrosis among the Indian population. According to Professor Mohan et al., higher prevalence of MESLD in the Indian population. Prevalence rate of MESLD is around 68%, and fibrosis 33%, cirrhosis 12.2%. Mapping study by Professor Dr. Mohan et al., it shows across different Indian population, higher prevalence of steatosis, around 60% and above, and significant prevalence of fibrosis, around 20 to 30%. So what is the culprit? Insulin resistance is a root cause for T2DM, high TGL and MESLD. This is a very popular slide. We have seen so many conferences. This is a twin cycle hypothesis of the etiology of type 2 diabetes mellitus and MESLD. So positive calorie balance in the background of insulin resistance, higher liver fat in the liver cycle, it leads on to resistance to insulin suppression of glucose production, which leads to elevated plasma glucose, which in turn leads to increased basal insulin secretion. Whereas when you enters into the pancreas cycle, higher liver fat goes on to elevated VLDL triglycerides, which lead to elevated islet triglycerides. In turn, it shows decrease in the insulin response to ingested glucose, which leads to elevated postprandial glucose, higher plasma glucose, which in turn leads to elevated basal insulin secretion. This is a twin cycle hypothesis. It explains both the T2DM and MESLD. So what is a shared pathophysiology? We told you it is insulin resistance in the background of environmental factors and genetic predisposition, which leads to adipocyte dysfunction, reduction in the adiponectin, which leads to elevated FFA and elevated TGL, which leads on to fatty liver under the background of lipotoxicity like inflammation, apoptosis and oxidative stress. It progresses to MASH and in turn development of T2DM and metabolic syndrome, this side end-stage liver disease. So what are the genetic factors in the MESLD? So one important gene, Indian gene, PNPLA3, is associated with increased liver fat content even in the normal weight individuals. So progress from MESLD
to keep silence. Please audience, keep silence for the presentation.
So progression of MESLD and MASH. So from the normal liver, around 25% of the people, they progress to steatosis. What is it? It is a fatty liver with trivial or no inflammation and no hepatocyte inflammation, that ballooning by insulin resistance. Around 3 to 6% of people, they move on to steatohepatitis, that is MASH. What is it? Fatty liver with significant inflammation and hepatocyte ballooning by ROS. And around 1 to 2%, they progress to cirrhosis, that is increasing fibrosis, leading to cirrhosis, and in turn at the end hepatocellular carcinoma. So there is a strong pathological association of MESLD with CVD, CAD, CKD and heart failure, etc. So having seen all these things, now we need to understand we have to screen early, detect it and intervene. So we have to go for screening and diagnosis of this fatty liver condition. What are the key screening criteria? Indian MASLD consensus, the patient sitting in front of you, any one of the cardiometabolic factors like T2DM or obesity or hypertension, dyslipidemia or PCOS or CKD, you have to go for workup for MESLD. So what are the major clinical practice guidelines? All the clinical practice guidelines like AASLD, EASL, ADA, all the guidelines, they recommend screening for MESLD in patients sitting in front of you like type 2 diabetes mellitus or patients with obesity plus more than one cardiometabolic risk factors or patient with persistently elevated liver enzymes. So how will you evaluate? How will you evaluate MESLD in patients with type 2 diabetes mellitus? So patient sitting in front of you, either diabetes or pre-diabetes, you have to go for exam, that is liver enzyme measurement, that is ALT and ultrasound. If the ALT and the ultrasound or normal, it comes to low risk category. For these patients, you have to go for periodic evaluation and standard care. Whereas the same patient, the same type of patients, the ALT and US examination normal, but long-standing type 2 diabetes mellitus. Number 2, evidence of steatosis. Number 3, A1C is more than 8.5. If the TGL more than 250, this patient, they come under high risk. Once you identify the high risk patients, you have to subject the patient for assessment of fibrosis. Another category, for the patients, ALT and US abdomen will be abnormal. Here you have to rule out other causes of liver disease. You have to subject these patients also for the assessment of fibrosis, either by MR elastography or transient elastography or fibrosis biomarker assessment. So, at the end of the day, after doing all these things, you come to know the patient belongs to no advanced fibrosis. If he falls under no advanced fibrosis, then the patient need to go for periodic evaluation and standard care. Whereas the patient comes to confirm that advanced fibrosis, we have to refer to the hepatologist and consider liver biopsy. For these patients, lifestyle plus drug treatment. Whereas in between, indeterminate, again you have to refer to hepatologist and you have to do liver biopsy. By doing the liver biopsy, you can come to understand there is a definite MASH or absence of MASH. So how will you assess a hepatic steatosis? One important thing is ultrasound imaging. This is a most commonly used tool to detect and grade hepatic steatosis based on the intrahepatic vessel blurring and the diaphragm attenuation. So you have to grade 1, grade 2, grade 3. And what is the use of this fibrosis 4 index? Fibrosis 4 index is a simple, highly sensitive, accurate and cost-effective test. If it is less than 1.3, low cutoff, rules out fibrosis. If it is more than 2.67, high probability of fibrosis. Fibrosis 4 index directly proportional to CV events, all-cause mortality and liver events. Elastography, fibroscan. This is based on the vibration-controlled transient elastography. By using this technology, you can assess a liver stiffness, which shows non-invasive quantification of liver fibrosis. At the same time, CAP score, controlled attenuation parameter, it shows non-invasive quantification of liver steatosis. So CAP shows the percentage of the fatty changes, whereas LSM shows the severity of the fibrosis. So MR elastography, it is most accurate form than VCTE in the patients with ambiguous cases, but it is highly costly. So how will you manage? Management of MESLD. So hepatic parameters, hepatic fat content, liver enzymes and lipid parameters one side, and glycemic parameters HbA1c and insulin resistance. What is it? FLA1c, fatty liver A1c. So it signifies the importance of managing both the conditions effectively, simultaneously to address these conditions and prevent the complications. So how will you manage? Lifestyle guidelines is very, very important, including dietary changes, weight loss and structured exercise intervention. So you can achieve the weight loss of 500 to 1000 grams per week by inducing 500 to 1000 kilocalorie energy deficit 1 and exercise both aerobic and resistance training, reduce the liver fat, and 7 to 10% of weight loss will help to improve the MASH and fibrosis, and moreover metabolic surgery is also helpful. So weight loss through the lifestyle modification. So even 3% weight loss leads to steatosis improvement, 5% weight loss, ballooning inflammation improvement, 7% weight loss, MASH resolution, more than 10% weight loss, fibrosis regression. So MESLD treatment algorithm, options for MESLD and MASH, pioglitazone, SGLT2 inhibitors and GLP-1 RA, they have proven significant benefits in NAFLD and CV risk. So breaking news from ADA. ADA recommends GLP-1RA, dual GIP and GLP-1RA and pioglitazone. They are recommended by the ADA for T2DM plus MASLD and MASH. So resmetirom, it is approved by the US FDA. This phase 3 MESO-NASH trial shows with the resmetirom, there is a NASH resolution and more than one stage fibrosis improvement. What about the ESSENCE study, which shows, evaluates semaglutide? It shows combined resolution of MASH plus fibrosis improvement. What about the tirzepatide synergy NASH trial? It shows improvement, that is a resolution of MASH without worsening of fibrosis. What about the saroglitazar? India first NCE, it improves the glucose metabolism, insulin sensitivity index. It is approved by the DCGI. So, when we come to the end of the session, 2 more slides. So, what is the expert consensus for MASLD from Indian diabetologist perspective? Here there are 5 things. Number 1, weight loss. We have to promote the weight loss. Weight loss is associated with reversal of steatosis and regression of steatohepatitis. Number 2, resmetirom, approved by the FDA for NASH with fibrosis, but it is not available in India and also costly. What about the saroglitazar? It is approved in India by DCGI for MASLD and non-cirrhotic MASH. This biopsy-driven trial shows that there is a NASH resolution at the end of 52 weeks. What about this GLP-1RA, pioglitazone, SGLT2 inhibitors, metformin? These are all off-label medication for MASLD according to Indian diabetology expert consensus. And what about the vitamin E, UTCA, omega-3 fatty acids, silymarin are listed? No substantial supportive evidence for continued use in MASLD and MASH. This is a final slide. MASLD is not just a liver issue. It is a metabolic, systemic condition deeply entwined with type 2 diabetes mellitus. Yes, liver is an endocrine organ, and as a diabetologist, we are in a unique position to screen this condition, identify this condition, and intervene early. You have to understand the evolving nomenclature, and you have to leverage the therapies like pioglitazone, GLP-1RAs, and SGLT2 inhibitors, which offer a dual advantage, improving the glycemic control and reversing the fatty liver pathology. Yes, the liver matters. Treating the liver means treating the diabetes at its root. Thank you for the patient listening. Thank you for my teachers and my friends. Thank you very much.
So indeed, thank you, Dr. Murali, for the thought-provoking presentation. It's very true. So the role of MASLD has got a very significant impact over the diabetes. As you said, it can lead on to many complications, not only micro, macro, but also the extent of fibrosis and hepatocellular carcinoma. Thank you so much. I think we are moving to the final session for this post-lunch session. So by stress in diabetes, so endoplasmic reticulum stress, so the increase in stress is going to cause the failure of your beta cells. So over to you, sir, Dr. Arthur, for your presentation.
So good evening, everyone. Respected chairperson, senior colleagues, my teacher, Professor Sundaram, and my dear colleagues. It's really a nice opportunity to be a part of this particular great venture, and I thank the organizing committee and the scientific committee for having given me this nice opportunity and also a nice topic of discussing ER stress in diabetes in your theme, what is going to be the future in diabetes management. I will take you through a little bit of introduction and explain what exactly is this ER stress and what is that which causes this and how does it occur, and also what is the relationship between the ER stress and diabetes, and whether we have any biomarkers for it, and what are you going to do with this? Are we able to treat it today, or just watch, or probably even go to an extent of prevention and end up with conclusion? So endoplasmic reticulum is a eukaryotic organelle fulfilling numerous biological functions. That includes protein synthesis and particularly the folding of the protein molecule, a 3D shaped molecule, vesicular transport, steroid and lipid biosynthesis. It orchestrates roughly 1/3 of protein synthesis, and it hosts natural folding of the proteins through ER residing chaperones and enzyme. These chaperones I will tell you a little later. Tracing the insulin gene and the insulin machinery which happens in the beta cell, the insulin gene has a transcription to mRNA, and this occurs in the nucleus and enters the cytoplasm through the nuclear pores, and it winds around the ribosomes of rough endoplasmic reticulum, and the tRNA or the transfer RNA goes on picking up the amino acids and attaching it to this particular mRNA, and finally it is just ripped off to form the particular peptide. So this happens in the endoplasmic reticulum, and beyond that, the folding, some of the folding and cleavages, all these things happen in the Golgi apparatus, and finally insulin granule comes out by exocytosis into the capillary. So this is just to show you, the blue one is a nucleus, the small pores are the nuclear pores, the mRNA coming out, sitting on the green endoplasmic reticulum, and there it organizes the synthesis, and the orange one is the Golgi apparatus, which also does the cleavage, and finally the molecules or the insulin granules come out and reach the particular capillary. So now what is this ER stress? Failure of the endoplasmic reticulum to align, compose and proper protein architecture leads to accumulation of misfolded or unfolded protein in the endoplasmic reticulum lumen, which disturbs endoplasmic reticulum homeostasis and provoke endoplasmic reticulum stress. In simple words, it's almost like a loaded bubble. The unwanted things which just get stuck in the large bubble is almost similar to the endoplasmic reticulum, wherein it is not able to dispose of the abnormal proteins as well as the abnormal folding of the protein or misfolding of the protein. So what do we really do? To respond to this particular problem or a stress, there is a cascade of signaling mechanism known as the unfolded protein response or UPR, which turns on to get rid of this unfolded or misfolded protein for restoration of the homeostasis. And what happens? If it is going to occur happily in a good turn, it clears off and the endoplasmic reticulum and the cell thrives. If not like that, it also helps to completely lose or destroy this particular entity so that the rest of the cell at least escapes. Now, what is the etiology for this? Many stimuli like nutritional overload, nutritional deprivation, oxidative stress, hypoxia, and even hyperglycemia and sulfonylurea do this particular trick. And excessive nutrient intake can overwhelm the capacity of the endoplasmic reticulum. That means it produces a lot of protein, so it gets stuck halfway through. It's almost like a pre-proinsulin coming out, or even just like a reticulocyte coming out in anemia. So this is what is happening in the endoplasmic stress time, and both it could be a cause or it could be the effect. And it also may predispose to CVD, atherosclerosis, hypertension, CKD, and even hepatic injury. So these are all the factors which act on the endoplasmic reticulum and stress it, and the two ways of meeting it out is death or survival of the endoplasmic reticulum. Looking at the pathogenesis is very interesting. The nutrient deprivation or overload, disruption of calcium, homeostasis or oxidative stress causes accumulation of the unfolded or misfolded protein in the ER stress situation inside the lumen of the endoplasmic reticulum. This causes high stress, and there is a thing which I told you, a remedy for this is an adaptive UPR pathway activation. If this activation is successful, well and good, it becomes okay. Adaptive UPR activation helps in transcription of the chaperones, which I'll tell you a little later, and degrade the unfolded protein. It's disposing the protein and initiate apoptosis of that particular protein, and finally eliminate the damaged component, and finally the endoplasmic reticulum becomes all right. Whereas if it fails, what happens? The maladaptive UPR takes over, and then it goes off causing the apoptosis pathway, pro-apoptosis pathway, and the ER stress associated apoptosis happens, and you get into problems like diabetes because the beta cells are lost. So this is a pictorial representation of it. On the right panel, you see the glucose roaming around outside the cell, causing hyperglycemia. And also you see the glucose is causing a lot of reactive oxygen species damage on the endoplasmic reticulum. And on the left half, you see small green, almost like a sausage. So these are the chaperones which are attached to the membrane of the endoplasmic reticulum and forms a very important component of the routine function of an endoplasmic reticulum. So these chaperones are present in the wall of endoplasmic reticulum. And the proper functioning of the endoplasmic reticulum depends on these chaperones. What are they? They assist in the proper folding. If this endoplasmic reticulum is not able to do that, it helps in assisting it for proper folding, for proper synthesis of protein, and also prevent protein aggregation. So it's almost like sticking with each other and finally forming a mass and clogging. So that's what I really said. It is almost equivalent to a constipated bowel, It gets clogged. So they also facilitate transport of protein to different cellular levels. And it identifies the target misfolded or unfolded proteins for degradation. It solves the problem of degrading these proteins. One more interesting thing which I came to know recently is this mitochondrial associated membrane. This is a special membrane which has a contact site between endoplasmic reticulum and mitochondria. I have never heard of all these things earlier. While I was preparing for this topic only, I really came to know. And this MAM resident proteins play a very vital role in the various cellular processes like development of endoplasmic reticulum, stress. This ERS may induce insulin resistance by disrupting the structure of the mitochondria-associated membrane. And this is what is probably happening when ER is getting stressed. It also spoils the mitochondria. When the mitochondria behaves in a different way, you are able to you are getting the ER also stressed up. So all these things spoil each other, just like what Muralidharan told you about NAFLD and diabetes. What is the role of this particular entity in clinical medicine as far as insulin resistance and insulin deficiency are concerned? So low-grade inflammation causes production of pro-inflammatory cytokines in adipose tissue, aggravate ER stress through the UPR activation, and also it down-regulates insulin signal transduction, the IRS1 and 2, and lead to occurrence of insulin resistance. So at the periphery, the same abnormality causes insulin resistance, and in the primary beta cell, what happens? The prolonged ERS signal can be detrimental to beta cell. It damages the beta cell itself, highlighting the importance of optimal UPR for ER homeostasis and beta cell function and survival. ERS also contributes to beta cell dysfunction and even onset of type 2 diabetes. High fat intake, which we thought that is going to just produce obesity, is also going to cause endoplasmic reticulum stress. And this causes maladaptive ER stress in beta cell, leading to beta cell destruction and apoptosis. So not only high calorie, but also high fat is going to damage ER and then the beta cell. So what is the relationship between ER stress and diabetes? So the maladaptive UPR may lead to beta cell death and also advanced glycation end product, which we discussed about blood glucose and its problems. That is also a triggering agent for this endoplasmic reticulum stress. Pancreatic beta cell resist maladaptive ER stress through production of adrenomedullin. This is a very important thing. So each cell, particularly the nephrons as well as the beta cells, they have a protecting mechanism of resisting this particular maladaptive ER stress. So how is it possible? With a hormone called adrenomodulin. And do we have the biomarkers? Yes, HSP40 and probably HSP27, but no clinical use at the moment. So looking at the treatment of this endoplasmic reticulum stress, the most important thing is again lifestyle modification and activation of an intrinsic ER stress resistance. So every cell should become resistant to this maladaptive UPR and reticulophagy and the concerned drugs that we are now using it. So calorie restriction, that is regarding the diet, weight loss, attenuates insulin resistance and alleviates maladaptive ER stress. Normally we think calorie restriction, weight reduction causes insulin resistance. We don't understand the link between these two. This is one of the links that we see. Another thing is CNB001, a compound derived from curcumin, significantly mitigated insulin resistance in obesity. And coming to the exercise, aerobic exercise activates ER stress and alleviates ER stress. And also it swimming attenuates maladaptive ER stress in cardiomyocytes. So maybe in any form of isometric exercise, this is going to be useful. Resistance training, we were talking about isotonic exercise. Now even resistance training has been shown to significantly reduce the levels of ERS. And exercise can reduce pancreatic beta cell apoptosis by alleviating ERS. So exercise, we say, is going to be acting only at the periphery. It's also protecting the beta cell. So exercise in any form, for anybody, at any point, is going to be beneficial. So this can even mitigate ERS by reducing the oxidative damage. Coming to the intrinsic ERS resistance activation. This is what is almost like immunization, wherein you are able to protect your cell from the invasion of UPS, which is maladaptive. So RAS activity resists maladaptive ER stress. Calcium calmodulin dependent protein kinase also helps in this particular entity. And the most important thing is aquaporin 11. All these things are things that we really do not have or know or hands-on experience, could attenuate ER stress. What is reticulophagy? When things are not shaping well, you close that particular entity. If your business is not okay in this particular segment, close it off. The same way, endoplasmic reticulum, if it is going stuck halfway through, destroy it. So that is what reticulophagy means. And this is one of the drugs which are able to bind and mark this particular entity. And the lysosome, which we know, which normally helps the macrophage to digest a particular organism. Same thing happens digesting the endoplasmic reticulum, which is stuck or defective. So it is really quite interesting. And common drugs which are used to produce hypoeuglycemia are very important, because hyperglycemia is going to mediate through ROS activity as well as this particular GAS5 and produce a lot of problem. Linagliptin decreases the top chaperone mRNA level in diabetic mouse hearts. And pioglitazone act by resisting the maladapting ERS through adrenomodulin, which I have already alluded to. And gliflozins, DAPA was reported to rescue against diabetes-induced cardiac complication as a result of ER stress inhibition. So very many hypotheses have been given for reducing cardiovascular mortality and morbidity with gliflozins, and probably one of them could be this. Hyperhomocystinemia, which could be corrected by a common drug like B6. Pyruvate is going to be used as a treatment. Nebivolol, which we have been using blindly for a beta blocker, is going to inhibit ERS, alleviating endothelial insulin resistance. Thereby, the endothelial damage or dysfunction is going to be corrected. And vitamin D also alleviates ERS in mature beta cells. So, where are we in prevention? Potentiating the overall capacity in cells and diseased tissues to effectively adopt an intrinsic ERS resistance. That's what I was just trying to tell you. Like, it's almost like immunizing a cell. The cell should be powerful enough to resist the maladaptive UPR. And mechanisms on maladaptive ER stress change could be a potential useful strategy to prevent the onset and progression of diabetes, obesity, and other non-communicable disease. So, dear friends, to conclude, accumulating studies suggest that both too much or too little. So you should not have UPR in excess nor in deficient state. Is detrimental to beta cell. So beta cell is a delicate cell, let us be very careful. Highlighting the importance of UPR-mediated ER homeostasis. And UPR function is required for a normal beta cell health and survival. Dysregulated ER stress response that is more likely to predispose to diabetes onset, suggesting that a functional homeostatic ER response is generally beta cell protective in vitro. So with that, I conclude my presentation. Thanks for the opportunity. Though it may not be useful for the next case that we are going to see, we understand things better, that there is some more entity like ER stress, which is involved in insulin resistance, beta cell dysfunction, onset of diabetes, as well as preventive measure. So we'll have this in mind. And as your theme goes today, future would be the answer. And at that time, we may be coming like Professor Seshaya, and at that time, we will all be talking about this drug improving in ER stress and that preventing diabetes with this particular entity. Thank you so much.
Thank you, Dr. Arthur, for the mind-blowing presentation. Now the floor is open for discussion. Any queries can be addressed now.
Dr. Muralidharan, it was a nice presentation. And what I would like to bring to this forum is efliximine is one of the drugs which can reverse the whatever the stiffness or the fibrosis, apart from resmetirom. That's number one. Sir, in the case of hyperhomocysteine, we do see commonly in our diabetic practice. I think so the drug of choice would be much of folic acid, along with B6 or pyridoxine. That also should be taken into account, sir. So, now, it is being a continuum, sir. Whatever we talk, sir, whether we talk about diabetes, whether we talk about obesity, we talk about NAFLD, whatever you talk and said, it is all a vascular, come inflammatory, come metabolic disorder. Everything is coined within one circle. It is a continuous, ongoing circle. So if you try to cut it, I think so you can get the results. Thank you, sir.
So what is the actual advantage of OCT over OCTA angiography?
So OCT and OCT angio are completely two different screening modalities. OCT in general is actually an imaging modality where we get a cross-sectional view of the retina. So it helps to get the retinal thickness as such, and mainly it is used in conditions like macular edema, so where we can get the retinal thickness accordingly. OCT angio, on the other hand, is an ultrasound-based imaging modality, and this is something which can replace FFA. So basically, we can find out any neovascularization or any ischemia. So more vascular-related issues can be picked out in OCT angiography as such. So PRP is indicated for proliferative retinopathy. So this OCT angio will help to pick out any pre-proliferative disorders, such as like peripheral ischemia in the early stages itself. So NPDR as such, we don't really treat with PRP. We just observe and we ask them to follow up regularly. So proliferative, on the other hand, definitely needs to be treated either with PRP or anti-VEGF, intravitreal anti-VEGF injections.
Thank you so much. I think we have completed this session on time. So before winding, we thank the organizers for giving this opportunity to chair this occasion. Thank you so much.